I'll just share it now. Can you tell me if you see the question?
Yes, it's visible.
All right, so your 1 minute time starts now.
Okay. Okay, I'm ready if you want to. Like,
You sure?
yeah, I'm
Okay.
ready.
All right. Go ahead.
So, hello. Hello. May I know patient's name? Like,
Hi, my
for,
name is Darshan. I'm just here to talk to you about the procedure the other day.
okay. Okay, so I will start now. Hello, Mr. Darshan. I'm Dr. Sonia. I'm one of the surgical doctor, and I've been asked to talk to you about investigation, uh, which would be arranged for you. Can I
Okay.
ask you what do you know so far about this?
I mean, I know I went for some test 2 weeks ago. I had to swallow something, and then they told me I'm coming
Mhm.
here today because I'm supposed to speak to you about a camera test.
Okay. Yes. Okay. I will tell you more details about it. And I have been told that you went that one test in which you had some liquid, and after that you were planned today for this camera test,
Yeah,
which is
exactly.
known as.
So, yeah. So I mean, I had the liquid test. It wasn't very pleasant. I hope it's not a repeat of the same test again.
I'm
Um,
sorry.
yeah. So I just like to know what test I'm going to go for next. Like I heard it's a camera test or something. So I hope
Yes,
not
definitely.
some. I hope it's not the same liquid that you have to swallow again and do a camera test.
Okay, definitely. I'm really sorry that your experience was not good,
No, that's
but
fine.
I will tell you the details about this camera test. So, okay, this camera test is called esophagogastroduodenoscopy, and this is also called as OGD as abbreviation. And in this, we will pass a small camera through your mouth, down in your food pipe, and then in your tummy, and then through that in first part of your bowel, and the camera will send us some photos which we will see at a TV screen, and in that we will look that whether your food pipe is doing fine or not, or whether it is having some changes, and if it will have some changes, then on the same time we will take one piece of that food pipe uh, through that investigation only. And just don't worry, you won't feel any pain. It will be you will be slightly drowsy. We will provide you some medication for that. Do you have any questions about it?
Wow. Okay. That sounds very unpleasant. Um, camera test. Will I be awake or is it painful?
No, no, it won't be painful. Don't worry. You will be, sleeping all the time, and you won't feel any pain. It will be totally a painless process.
Oh, okay. So will I be put to sleep then?
Not exactly sleep. You will be slightly drowsy in a small
Okay.
amount of
Okay.
sedation.
Okay. All right. Okay. Okay. That's a bit daunting. Okay.
Do you have
I've
any other
not gone through
questions?
this before. Are there any, risk or anything? Because I think my uncle had a camera test and then he told me like, he was given
Uh,
a leaflet and he was told about like
mhm.
a lot of information about it.
Okay.
Any risk, if I go through this camera test?
Yes, definitely. I will tell you about this because every procedure has some risk. So, In this procedure, there are few risks, but chances of those risks are very minimal. And risk will be like while introducing that camera, there by mistake some damage to your tape or some infection to your chest, or maybe when we take piece of your bowel, in case we need that, then chances of bleeding can be there, or maybe there can be some serious risk like any injury to your food pipe can also be there. Otherwise, but chances of these will be minimal,
Oh,
I
okay.
hope.
So what do I do then if whatever you said happens, what will go on then?
You need not to worry about these risks. You will be in completely skilled hands, and if by chance anything goes wrong, then you will be immediately treated for those risks. Experienced surgeons will be there. I don't think you need not to worry about that.
Oh, all right. So that means we'll have to go through an operation then if something happens.
Um, we will try to control that thing by that camera thing only. You need not to worry that we won't be opening you if something goes wrong.
Okay, okay, all right, okay.
Do you
That
have any other question?
I mean, one more thing. Why? I mean, I since the procedure. I mean, 2 weeks ago, I keep
Mhm.
salivating. Like I have to always have a tissue at hand. When I go
Okay.
out, it's quite embarrassing.
Mhm.
Why? It's quite. It's affecting me when I go to work and I go out. Um, you know,
Yes,
I mean,
I can I can understand, and I'm really sorry you are going through this. But the best explanation for this is that maybe there is some narrowing in your food pipe, which is causing your secretions to come back, and they are not
okay,
easily passing smoothly downwards. So that's
yeah,
the main reason.
yeah. So I read about it online. I went on Google and all that, and then they all keep mentioning about cancer. So my wife and I were quite worried. So do you think it's cancer? I mean, what's going on?
I can understand that these things are genuinely giving you stress, but
Yeah, yeah, it
will
is.
be it will be too early to confirm that this is a cancer or something else. For that, we will first investigate you properly, and after that, we will confirm you about it.
Okay, so is it cancer or not?
No, it will be very early to say that it's because of cancer.
Okay, so is that why you're doing this camera test?
Yes, we will do the investigation like this
Okay,
camera test, and if we will suspect something, then we will do
okay,
further investigations.
okay, okay. All right. So how long do I have to wait then after this test to find out if it's cancer or not?
Uh, you will get around 2 weeks. In 2 weeks, your all the doubts will be cleared, and I can understand your apprehension, but we will inform you within 2 weeks.
So 2 weeks of worrying then. Not nice. Okay,
I'm
okay.
sorry.
All right. Okay. Um, okay. You have to stay in hospital then.
We will keep you till evening until you will be recovered fully, and then we will allow you in late evening to return back home.
Okay.
And but the main thing is you won't be allowed to drive, so I will advise you to bring someone with you so
Yeah,
that
my wife
you.
my wife will my wife will bring me. So I think she can drive me home.
Okay, that will be the great thing. And in evening we will discharge you. Don't don't worry.
Okay.
Do you still
Okay.
have any questions?
Yeah, I mean, what about the test 2 weeks ago? Like, what happened? Have you seen the results? Anything abnormal? Um, so
Your that test basically show that there is something which is pressing at the lower part of your food pipe, and it would only tell us about that. There was not much information available with that test. So those findings will be confirmed by doing this camera test.
okay, then what's the point of doing the test then 2 weeks ago? If you can just do the
Uh,
camera test directly.
We first do the sometimes there are some conditions which can which are like simply diagnosed by doing that drink test, and when we are not able to find anything on the drink test, then we proceed to our camera test. So first step is to undergo that. Do
Okay.
that.
Thank you, Sonia. All right. All right, well done. All right, so time's up. Okay. Okay,
Thank
so
you.
yeah, well done. So how do you feel? How do you feel that went?
I was a bit nervous in between. Otherwise, I think I completed my station on
Yeah, yeah.
time.
I was trying to throw you off by asking many questions in between and trying to interrupt your flow. Um,
Yes.
Especially, I mean, that's what many anxious patients will do, especially like a patient who's been worrying about cancer. They will
Yes.
try to not, I mean, they're not trying to interrupt you. They will have many questions to ask. So, uh, I mean, the purpose of the whole thing was to try to throw you off your train of thought. Um,
Yes.
but yeah, so yeah, I mean, you were a bit nervous, but you did it well. I think that's the whole point of the station. It's not a one-way thing. It's a two-way thing. Mostly on the side of the patients, they'll ask you lots of questions.
Yes.
But yeah, I think you did well. So the first thing is that you know we'll go through the start. So the first thing is try to utilize that 1 minute. I mean, of course you were ready. You told me that you were ready, but utilize that 1 minute. They give you 1 minute for a reason. Read the question properly, and then
Okay.
go into the station.
Okay.
Because there are clues. I mean, of course, when you go into the station, the question paper will be pasted on a desk nearby on your chair, next to your
Yes.
chair. So don't have to worry because sometimes you might lose your train of thought as to what the question is, and you can just have a quick read. But use that 1 minute first to actually read the question properly, calm down, keep your thoughts, and then go into the station and be confident.
Okay.
As to the, I'll just share the slides now, and then we'll go through one by
Yeah.
one. Um, just a second. All right, can you see the slides now?
Yes. Visible.
Yeah, so as you can see from the station, um, it's counseling for an OG dilatation and biopsy um, after a barium swallow. Okay, because they found some narrowing on the barium swallow, probably a stricture or something sinister, and you've been asked to see the patient and counsel the patient with procedure.
Okay.
Okay, so the first thing you did was, of course, you introduce yourself. You, of course, you have to check my name and date of birth, which you did. And you also have to ask the patient, like, do you know why you're here? And what do you know so far? Okay.
Yeah.
In this, I mean, of course, it's very generic, like all these prompts and all that on the slides. But when you go into the station, I mean, the patients are all actors, very experienced actors. So try to look at them and speak to them as in you're speaking to an actual patient or
Yes.
someone you know is going through this worry about, possible cancer. Try to be empathetic. Try to ask them like, how was the test 2 weeks ago? I hope it was okay. Do you know why you're here and all that? So try to be more empathetic when you ask them those questions.
Okay.
Okay, that kind of opens the door for them to be a bit more relaxed when you go through the entire station.
Okay.
Okay, so you did well. You kind of told me what an OGD is. Obviously, don't go through this whole spiel. Just tell them it's a camera test going through your food pipe down to your stomach, having a quick look, and then looking at the first part of your small intestine, okay, called the duodenum. I mean, they won't understand what duodenum is, but just tell them like we're going to have a quick look. If we see something, we're going to take a small tissue sample, or what we call a biopsy, and then come out. That's it. Quick
Okay.
and easy. Okay. So don't kind of bother them with terminology. The quick look
Okay.
with the camera down the mouth into the food pipe, into your stomach, and the first part of your small bowel called the duodenum. If everything's fine, take the camera out and you can go home after that. Or if you see something, we might just take a tissue sample or biopsy and you can go home and we'll contact you in about 2 weeks' time.
Okay.
Okay. So of course, when you tell them all these, just make sure to be slow. Tell them very, be empathetic with them.
Okay.
Okay. So of course, these are questions that the patients will ask, like, is it painful? Especially those who haven't gone through a camera test or a scope before. Is it painful? Will they be awake? So you can tell them, like, it's either under sedation, light sedation, with a spray at the back of the mouth or throat, or under GA, where we put to sleep. And you can tell them that it'll be decided by the anesthetic colleague. Okay, so you are no, I mean, you usually the surgeons won't decide. It'll be the anesthetic team which will decide. Okay,
Okay.
but you give them the two options, either GA or under light sedation.
Okay.
All right. Any risk? Okay, this is the big one where they actually mark you on. Because when you consent a patient or when you actually explain to them about the procedure, if you tell them about risk, and I think what's the biggest risk in a scope that you have to tell them about?
It will be perforation.
Exactly, a perforation. So, I mean, you have your common surgical risk with infection, bleeding, damage to surrounding structures, but I think the most common, I'm not most common, I think the most obvious risk you have to mention to the patient is a perforation. I'm not sure if you mentioned that, or maybe I didn't catch it. Did you mention a perforation?
Yes, I tried to that there can be rupture to the food pipe. I
Yeah. I
mentioned in.
think try to avoid using the word rupture because that's quite.
Okay.
I mean, a patient who has no medical knowledge, that'll be quite a big term. Imagine
Okay.
just one of the risks is a rupture of the food pipe. It's going to be very catastrophic for them.
Okay.
So put them in your put. I mean, try to be in their shoes and then try to. So you can tell them, like, as a probably a perforation or just a hole in the food pipe, which can happen as a result of
Okay.
the camera test. So tell them about, like, like you mentioned, infection, bleeding, damage to surrounding structures. But the most obvious thing is a perforation, or you can just say a hole in the food pipe. Okay. And of course, try to reassure them that these are all risks. There are risks with every procedure, but these risks are minimal. But I still need to make you informed and aware that this can happen.
Okay.
You can try to reassure them that if these happen, then we can take steps to repair the damage.
Okay.
Okay. So, but try to reassure them that there are risks, but it's minimal. I have to make you aware before you sign on the consent form.
Okay.
Okay. So I mean, these are all things you have to do as a surgical SHO when you're working here. You'll be doing all this consenting, so you have to make them. You have to do this, so it's part and parcel of working here, and as a surgical SHO. So you'll get used to it when you come here and work. But yeah, just for OGD, colonoscopy, perforation is the most important complication you have to mention.
Okay.
Okay. Um, all right. So of course, being dramatic, I have to ask, like, what happens, and I don't want to go through an operation. I think you kind of managed that quite well. And then I asked you, like, why do I keep salivating? And of course, I tried to kind of ad hoc try to tell you that I looked up Google, and the most common cause is cancer. And so that was trying to throw you off and trying to see how you manage my questions, and how to calm the patient down. Okay, did that quite well. Now, is it cancer? Of course, you said, like you told me, I can't tell you much about it because hence why we're doing this test, to do the camera test, to do a biopsy, to see what it is actually.
Okay.
Okay, so don't tell them if it's cancer or not. Don't say yes or no, which you did. Just tell them, like, we don't have an answer, hence why we're doing all these tests.
Okay.
Okay. All right,
Okay.
I think you did that quite well. You deflected my questions quite well. Um, and then asked you, like, when will my results come back? Um, of course, patient who's anxious and worried, that's what they want to know. Um, Obviously, histology takes about 2 to 3 weeks to come back. And then you kind of deflected the question well. You kind of calmed me down, reassured me that it'll take time, but we'll let you know when it comes back. Okay, so
Okay.
you did that quite well. And then I think the last question, do I have to stay in hospital? Yeah, it's usually a day case procedure. If they go through GA, they might need to stay overnight. If they go through light sedation, they can just go back home in the evening, provided that someone drives them home, which is really good. You did that quite well, because you have to have someone to actually accompany you. You can't drive home on your own. Okay. And then I brought back questions to my previous investigation, try to see if you can, although I didn't give you the results of that barium swallow, but you did quite well. So I think the last thing probably which ran out of time because of my constant questioning, you kind of didn't summarize. But I think all in all, you did quite well. I think at the end, just to say for any procedures, especially OGD and colonoscopy, just to close the session, you can tell them like, I can get you a leaflet for OGD that should have the answers to all your questions. And you can provide a number. You can tell them you can provide a number to the ward or to the office if you have any questions so that they can call you back. I mean, although you won't have the leaflets in the station, but it's just like, as in clinic and all that, when you see a patient to consent for OGD, usually give them a leaflet that will explain the procedure, pre-op, what to do, fasting instructions and all that. So just tell them in the station. So the examiner will say like, okay, this candidate has some knowledge about, preparing for patient empathy and all that.
Okay.
All right. So I think you did well. Just practice and just try to practice with friends, especially ask your friends to be more persistent when questioning you, because patients here are very persistent. They're not persistent. Of course, they're anxious, they're nervous, they'll ask you lots of questions to they'll kind of tend to throw you off, especially in a station where you have 9 minutes and you're under pressure. But I think you did that quite well. Just keep on practicing till your exam. You'll be fine.
Okay. Thank you.
Okay, any questions?
No, thank you.
All right, no worries. Okay, so stop this and then we'll go on to the next station. Any volunteers?
Anyone interested for phone call station SRIC?
So we have Diba, Nazir, Rahima, Shakila, Sonia, Sri. You guys have a think, or I'll just start randomly picking on one of you guys. All right, Sonia said that she can do it if you don't have any volunteers. Everyone happy with that? Fab, we'll go with Sonia then. Sonia, you ready?
Yes, I'm ready.
Okay. All right, guys. So, guys, be more proactive. It's your exam. You're going to sit the exam. So, these Zoom recording sessions are for your benefit, for you to practice. So, try to be more proactive. But Sonia has volunteered for the second one as well, so we'll go ahead with her. So, Sonia.
Yes.
So, let me get the station. So, same format as the last time. 1 minute reading time, 9 minutes of your performance, and then we'll go through the feedback. Happy?
Yes.
Okay. Just 2 seconds. Let me just bring up the slides. Okay, Sonia, for this, I haven't shared the slide yet, but you read the question, but I'll give you the findings, the examination findings, and also the lab results. So if you have a pen and paper ready, just try to jot them down.
Yes.
Let's speak to you. Will that be okay? And then
Yes.
when you are ready, when the 1 minute's up, we'll start the station.
Okay.
Okay. All right.
Yes, I'm ready.
Let me just get my phone. All right, your time starts now.
Okay.
Can you see the slide, yeah?
Yes, I can see.
Yeah. Let me know when you've read the question, I'll give you the findings.
Okay, sure. Fine. Uh,
Happy?
uh, yes.
All right, so I'll give you the findings, yeah? So this is Mrs. Dorothy Jones. She's come in with just generalized abdominal pain for 2 days. CT showed a suspected perforated viscous with pneumoperitoneum. On examination, her abdomen, there's generalized guarding with peritonism, and just pain everywhere. Blood test results came back showing a HB of 85, baseline being 120 a week ago when she had the test done in GP. Other blood tests were all fine. Use in ease came back. So potassium is 2.9, baseline was 3.8 last week. Creatine's up from 250 from 110 a week ago. Okay, urea is up to 19.5, up from 8.5 a week ago. CRP is 220, her baseline being about 40 last week.
Can you please repeat last one?
CRP is 240.
CRP is okay.
Her baseline being 40 a week ago.
Okay.
All right, blood gas results, which were done. So an ABG was done. So her pH was 7.2.
Okay.
Normally a pH runs about 7.36 because she has COPD.
Okay.
It's compensated COPD. Her lactate is 5.1. Lactate was normal last week. Base excess is minus 3.2.
Okay.
Do you have everything down, or do you want me to repeat the values?
Yes, I must.
Okay.
Can you please tell again clinical findings?
Okay.
She had
So
abdominal.
yes. So on examination, there's generalized abdominal guarding with peritonism and pain. No localization, it's just generalized. No palpable masses, nothing that you can find. It's just pain with guarding and peritonism. The CT is kind of confirmed a perforated viscous with pneumoperitoneum.
Okay, I'm ready.
Okay, so now you're supposed to phone the ITU registrar and get his advice. Okay, you ready? Yeah?
Yes, I just want to confirm before starting. What is the consultant's name? Because I will have to introduce consultant. Is it so?
The ITU registrar's name is, you mean consultant's name or the ITU registrar I'm going to speak to?
Consultant's name, whose case it is, because sometimes in this scenario,
the consultant's name is John Appleby.
Okay.
Mr. John Appleby. He's a colorectal consultant.
Okay.
Okay. All right.
Okay,
so you're ready? I'll start the time now. All right.
Okay, start.
All right, you doing go.
Hello.
Hello. The IT registrars.
Hello, I'm Sonia. I'm a SHO working in colorectal department. I'm calling you to speak about the patient. Are you free? Can we talk now?
Yeah. I mean, of course, I got your bleep, so hence why I'm calling you back. Why are you calling?
Yes, I'm calling you to talk to you about a patient, Mrs. John, 73-year-old female. We admitted today, and I'm calling you to ask.
Is this urgent? Like, have you spoken to your registrar about it?
Am I speaking to ITU registrar?
Yeah, no. Have you spoken to your surgical registrar about it before calling me?
Yes, I have spoken to my
Okay.
surgical registrar, and
All right.
he asked me to talk to you.
Okay, so your registrar is aware of the patient, yeah? Okay.
Yes.
Okay. All right. Because I have a
So
patient with asthma coming in, with status asthmaticus coming in. So can I call you back, or is it urgent? How urgent is this call?
actually, I'm calling you to for an urgent emergency patient only who is unwell, and we are sending that patient for laparotomy, and that patient may require HTU bed
Okay.
post-operatively.
Okay, tell me. So what's the patient's name, and why is the patient going for laparotomy?
Yes, I'm calling you to inform about Mrs. John, 73-year-old female. She presented with a sudden pain abdomen, and now she's having on a clinical examination. There are signs of guarding and peritonism, which are confirmed on CT finding. And currently, her blood is showing metabolic acidosis with high lactate levels, and she is in acute renal failure also, and she is a known case of COPD. And we are taking her for surgery for perforated viscous, and her CRP levels and hemoglobin level is also low, and CRP level is quite high. And on CT, there is a free intra-abdominal collection.
Okay, so you've done some imaging which showed a perforated viscous, is it?
Yes. So can you please advise me about something about optimization before theater?
I mean, I'm not near a computer now. So what's her HB? What's her blood test results? And what's her, you said that she showed some metabolic acidosis. So what's her ABG results? I can't advise
Yes.
on words.
Okay. I can inform you about that. Her hemoglobin level is 85, and usually her baseline is 105. And her CRP level currently is 400, which is baseline is 40. And blood urea is 19.5, which is 8 earlier last week. And potassium is 2.9. And her ABG is 7.2 pH, and she is COPD patient. And lactate is 4.1, and base excess is 3, minus 3, negative 3.
Okay, so that's quite significant findings, isn't it? So what are you
Yes.
doing with the HB of 85? Are you going to transfuse her? Have you cross-matched anything?
Yes. Yes. Currently, we are resuscitating her by crystalloids,
Okay.
and after that I'm also sending cross match for blood in view of hemoglobin fall and more during the surgery, and we
What
will transfuse.
did you say her background is? Like, what's her past medical history?
She is a known case of COPD.
Okay. Just COPD?
She's only and also currently she is in acute renal failure.
Okay,
with
she's not
hyperkalemia.
on any anticoagulants like warfarin, apixaban, rivaroxaban, or anything of that sort.
I will cross check it and will let you know. I don't
That's
have
fine.
information about it.
That's fine. Why do you think it's a perforated viscous?
Because they on examination she is having guarding and peritonism,
Okay.
and on CT scan also there is a free intra-abdominal collection.
Okay. So you're going to arrange for theater, yeah? Okay. And
Yes.
have you discussed with your registrar and your consultant?
I've discussed this with registrar also, and he has discussed with the consultant, Mr. John.
Okay.
And after that, I called him.
Okay. So I'm sure the anesthetic team's aware. So you're calling me again for advice, is it about what to do?
Yes, pre-operatively, for pre-operative arrangement, what do you think? Is there any other thing I should take care?
Okay. Okay, we will get to that. So, like, have you started on fluids? Have you given her any resuscitation fluids?
Yes, we have resuscitated her by giving her 2 liters of crystalloids rapidly, and cross match is also sent, and I'm waiting for blood.
Okay, all right, okay. And what do you say her pH was in the blood gas?
Her pH is 7.2.
7.2. Okay, all right. Okay, I'll give you a few instructions on what to do while you wait my colleagues to come down and see her in resus.
Okay.
Okay. first, I'd like you to get 12-lead ECG,
Okay,
get a
sure.
portable chest X-ray. I
Okay.
hope you're writing this down because I'm not going to repeat this again.
Yes.
Okay.
Yes.
All right. So start on antibiotics, so broad spectrum antibiotics.
Okay.
Okay. Check if the patient's on steroids. If not,
Okay.
give her IV hydrocort.
Okay.
Okay, 5 milligrams per kilo.
Okay.
Okay. And then you said she has COPD, isn't she?
Yes, she's a non-case of COPD.
Okay. Do you have PO2 and PCO2? Do you know if she's retaining or she's not? Do you know if she's type 2 or type 1 respiratory failure?
Currently, I don't have information
It's
about the
fine.
question.
It's fine. I'll just try to keep her saturation targets low, so just 80 to 92% because of a view of COPD.
Okay.
Okay. And I hope you have contacted the on-call anesthetic team to review the patient in resus before the patient goes to theater.
Definitely, I will confirm that too and
Okay.
will
So
inform you.
make your registrar aware, make your consultant aware, call the on-call anesthetic team, keep the patient near by
Okay.
mouth. If the patient is conscious, make the patient aware of what's going on. Tell her that, we're
Okay.
going to bring her to theater and get a consent form done.
Sure, I will do that.
All right. So,
do you want me to repeat what?
yes, please repeat what I've said to you.
Okay, I will take the consent from the patient. I will check for ECG and chest X-ray and broad spectrum antibiotics. And also, I will check if patient is on steroids. Otherwise, I will start the IV hydrocod 5 milligram per kg. And if patient is COPD, so I will cross-check her oxygen saturation and will inform you. And I will also check whether anesthetic team is informed or not.
Okay,
and I will get
good. Save everything down. So do that after you put the phone down, and make sure your registrar is aware, make sure the consultant is aware. Give Kate a ring and book her for a laparotomy. Okay.
Sure, I will do that. Okay.
All right. Is there another thing you wanted to ask me?
Yes, I want to book you for. I want to book this patient an HTU bed also after post-op, means in post-op.
I mean, there's only one bed left, and there's a patient I told you is coming in with status asthmaticus. So I think I think she's probably going to take the bed. So
Okay.
I don't think
we
I have
can
a bed.
plan for ITU. Means if not in ITU, we can means HTU. We can plan for ITU bed.
Okay. I mean, these patients need an ITU bed post-operatively, but like I'm telling you, there's no bed. There's only one bed left, and there's a young lady coming in with asthma as I'm speaking to you on the phone. So I don't think that
Okay,
bed is
sure.
going to be there when the patient comes out theater. So what I will, right? That's time's
Okay,
up.
I will manage this. I will manage this patient in recovery. Okay,
Sonia, thank you.
okay, thank you.
All right. So I'll stop you there. Okay.
Okay.
All right. How was it? How do you feel?
I think I was doing fine, but then in later phase I got confused
Yeah.
when
So
you said that
this is not
another
a
patient is coming.
yeah. So this is not very optimal station to do via Zoom because in the actual
It should be
station you have
expression and
you have
yes.
7 minutes to go through the patient notes, and you have a piece of paper to write down everything, and then you have 9 minutes to go in and speak to the registrar on the phone. So it's not an ideal station, but I mean we did our best. But yeah, like what you said about the that asthma lady coming in, that was that happens all the time. I mean, they will always ask you like there's someone else coming in, or there are very rare days where the IT will say like, oh yeah, there's a bed here, patient can come in straight away. So sometimes it happens where it's a bit of a conflict between two patients. So who needs the bed the most? So that was kind of the last question to throw you off. But yeah, so how do you feel about the whole thing?
Slightly nervousness with practice. I think that will go.
Yeah,
Otherwise, it was fine.
I think you did quite well. Normally ITU registrars are quite nice, but there are some ITU regis who, I mean, because of being busy and unwell patients, they can be a bit hasty. And so I tried to throw you off initially when I asked you like, why are you calling me? Have you spoken to your registrar first? And your consultant, rather than calling ITU straight away. So that is a very common question that they ask, because in this scenario, you're just the SHO. You would have escalated to your chain of command. So your registrar, your consultant, and then they would have advised you to call the ITU team. So that's why, but you did that quite well. You said that I've spoken to my registrar, and they have advised to call you. So that's good. Because if you had said the other thing, which I've not spoken to my registrar, that's it. They'll be like, I'll put on the phone, speak to your registrar first, don't call me first. Okay? I did that quite well. Yep, Rahima said you can't make up stuff. No, good question. I didn't actually tell her that you've spoken to the registrar, but in the scenario when you go for the actual exam, they would have said in the case notes that you've spoken to the registrar. So that's normally the case, because you have to escalate to your hierarchy first before you call another specialty. Okay, so we'll go through the slides again. I'll just screen share the slides. All right, can you see this?
Yes, it's visible.
Right, okay, so you did that quite well. You introduced yourself quite well. And then your case summary was good. Obviously, they will say that, you gave me, metabolic acidosis by all that day, but they just want to hear values. Hence why in the actual exam, when you have 7 minutes to actually read the notes, they're not giving you 7 minutes to just chill. They're giving you 7 minutes to actually read and write values. Because most of the time they'll be like, I'm not near a computer, so I can't check the results for, as you're speaking on the phone. They would like to tell you the results on your own. Okay. So, and then tell them straight on the phone what you want. Free of advice, and then to arrange a HDU bed after, which you did quite well. I think this question is a bit of a, you already told me that you did a CTB should perforated viscous, but I had to ask you because it's on the slides anyway, but you did that quite well. Basically, they wanted to see what you found on examination, and what imaging you did, which confirmed the finding, which you did quite well. Okay, so fluid resus asked you, and then you said crystalloids with the HB drop while waiting blood transfusion. So remember, for bleed or HB drop, blood for blood, not fluids. You can give fluids temporarily. In this station, I didn't give you the observation findings. I didn't give you the blood pressure results and the heart rate and all that. So I didn't want to ask you about that. But in the actual exam, they'll give you everything. They'll give you the patient's findings, observations, blood tests, ABG, chest X-ray, CT, everything. So it's a whole file of notes, and you have to go through and write down the values. Okay. And then these are the advice that I gave you. So IDC insertion, I didn't, normally anesthetics will do it in theater. In the anesthetic room before theater. So you don't have to do it yourself. And then antibiotics, IV hydrocort. If the patient's retaining, in the ABG, I didn't give you the PO2 and PCO2. So you did well to say that I didn't know the PO2 and PCO2, but we kept the patient on the type 2 scale anyway. It's good. And then always call the on-call anesthetic team. Okay. Normally, in hospital here, besides the exam, you don't call the ITU registrar to organize a bed. Usually, when you call the anesthetic on-call team, they will liaise with ITU to arrange a bed post-op. You don't have to do anything. But I think this station is a very old station, back in the early 2000s. So I think back then it was a different system. Okay. I forgot to ask you this, because we were going on, but the criteria of admission to ITU. So I presume you know.
Yes.
Admission criteria to ITU and admission criteria to HTU.
Yes.
Okay. So some hospitals, they are big tertiary hospitals, they have HDUs and ITUs. They have a surgical HDU, medical HDU, and they have an ITU. My hospital is a district hospital. They don't have HDUs, they only straight to ITU. So it kind of moonlights.
Okay.
So even though a patient who needs NIV for type 2 respiratory failure for COPD goes to ITU. So that's how my hospital works. But tertiary big hospitals, they have level 2, level 3 care. Okay. So, I mean, this one, I mean, it's more of a question and answer session, but we didn't have time to go through it. But the whole thing is to see how you actually, you know, answered my questions and how you know, to see whether I can give you the right advice. All right. So, and all these, how do you calculate potassium deficit? I mean, I've not seen a question where they ask you this, but good to know for knowledge. They might ask you this or this. How to replace potassium? You probably should know this as well. And then this is the one where I had to throw you off by saying there's one other young lady coming in with asthma. So how do I? What do I do? Okay. So in this case, you're the SHO. You can tell me that, okay, if that's the case, I will let my registrar know and let my consultant know, and we'll take it from there. Because you are the SHO, you don't have to, your duty is just to call me and get my advice and see if there's a bed. Me on the other side of the phone, I already told you, well, I don't think there's a bed ready. And you're like, okay, if that's the case, it's fine. I'll escalate back to my registrar. So always escalate, because you're not the highest in the hierarchy, so always escalate. You're the SHO, get your registrar involved. Okay. All right, so I think that's us for I think overall you did quite well. It's just me trying to show you off and trying to ask you questions in between your answers, but you did well. Any questions?
Yeah, no questions. Thank you.
Thank you so much.